Okay, so normal newborn, we start, first things first, starts with, actually even before the APGARs, and I'll talk about this in a minute, it starts with the history and the delivery and so on. But I want you to remember the importance of the APGARs and how that can give you an indication to what you need to focus on in terms of your assessment and how this baby is going to adapt to extrauterine life. So those are just reminders about APGARs. So we'll start here with adaptation and assessments. All right. So surfactant is detectable by 24, 25 weeks gestation. Detectable, but not sufficient. It's usually sufficient between 34 and 36 weeks, more like 36 weeks is what we tend to see more in practice, more like 36 weeks. So a couple of things contribute to the first breath, and these factors also play a role in the continuation of respirations. So our chemical factors include chemoreceptors. So as the levels of blood gases change, the oxygen and CO2 as that changes. So in utero, the fetus actually has a lower PO2 than extrauterine, right? The oxygen, it can tolerate a lower oxygen level. And we talked about all of those protective compensatory mechanisms, like about the fetal hemoglobin. So the actual PO2 is actually a little bit lower in utero than externally. Mechanically, vaginal delivery, the fetus gets a chest compression squeeze on the way through the birth canal. The thoracic cavity is compressed. And so that compression results in almost a reflexive inhalation. Tactile stimuli, us touching the baby, is one of the things that contributes to that first breath. Skin sensors, the room, wherever the environment is, and I think we might have talked about this before, but if in case we haven't, what is the average room temperature? Like, what's the likely temperature of the room that you're in right now?
25, 30, 25, 25.
A little less.
20, 22.
So I would say probably around 22. So what about for the rest of you? Fahrenheit? Guess?
70.
Question.
70, 75.
70, 75. Okay, so typically somewhere around there, 72, 74. That's around our average room temperature where we're comfortable. What is the temperature of the environment this baby just came from?
37 degrees Celsius. Or
37, 98.6.
Yeah.
No matter how you cut it, whichever system you're using, there's a significant drop in temperature, okay? So it's like when you, you know, come out of a pool and it's a little bit cool outside, or you come out of the shower and the bathroom isn't quite that warm. It is a tactile stimulus, and it makes you inhale, okay? So remember that, keep that in mind. The room of the delivery, there are visual stimuli, auditory stimuli, there are different sights, things that the fetus is hearing more clearly, not hearing it through the amniotic fluid, it's not muffled anymore, right? Different smells, the tactile stimuli, visual stimuli. The fetus is seeing in utero, okay? But now, again, there's no amniotic fluid, there's no abdominal muscle and skin. Everything is bright, everything is loud, and the fetus is in a colder environment, and here we are touching him, all right, or her. So
That's why they are very angry. I mean, the facial expression is always angry when they come out.
I don't know if they're always angry. It's
Well,
startling. It's startling, right? Look, you're coming from this a huge change in environment, right? So the initiation again of respirations, lots of things that contribute to that internally and externally. All right, so there's that initial inhalation. Surfactant, I'm not going to talk a lot about surfactant now. I'll save that for Unit 3 because it really plays a big part in our preterm babies. But just surfactant does keep the alveoli partially open, so we need an adequate amount of alveoli. Some of the air from the first breath becomes residual capacity, so between the residual capacity and the surfactant, it makes subsequent breaths easier. So it's that first one that's the hardest one for the fetus, for this fetus newborn, and thereafter it should become a little bit easier. So I mentioned the squeeze to the thoracic cavity. The remaining amniotic fluid that is in the lung tissue is absorbed by the lymphatic system. So surfactant we talked about from the LS ratio, yes.
okay.
Right. Okay, so I think I'm getting my classes confused. Remaining fluid is absorbed by the lymphatic system. What about our babies who are C-sections? What about our babies who are C-section? They didn't get a squeeze.
You got suction on this?
Yeah. That's happening.
So what are you expecting to happen with them? They're going to have more fluid, right? More
Yes.
fluid in their lungs. So would you suction? I want you to think about where is the fluid? Where's the fluid, Fred? So
No.
in they've been swimming and breathing. So this amniotic fluid is all everywhere, right? Inside and externally. So where's this fluid though?
The fluids, I mean, it's in their lungs.
But is it, so I want you to think about the anatomy because this is important, not just for this, but for going forward. So remember,
I guess it would be in everything.
Respiratory stuff. Where
It would
is
be
it?
in
Is
everything.
it-
The lungs, the digestive tract, like the whole thing, like it's throughout the
Okay.
Upper and
But the fluid that you're mainly concerned about, is it in the airway or is it in the tissue of the lung?
Oh.
That's what I want you to start thinking about, right? Because then that determines your actions. So think about it. If a patient has fluid, whether amniotic fluid or phlegm or whatever, if it's in the airway, you can suction that out. If it's in the tissues, can you suction that out? No. If it's in the tissues, and most of this amniotic fluid is in the tissues. So what are we going to do? What do we do to mobilize fluid that's in the lung tissues? So when you learned suctioning last semester in fundamentals, you should have learned suctioning and, why is it so quiet? You guys are so cool. What's happening? So when you do your, what we call pulmonary toileting, right? Chest physiotherapy or chest PT.
oh, the cup, like
Chest PT, you got to get that fluid moving. Yes. So again, the principles are the same. Principles are the same. You just have to think about how I'm going to apply it here. How am I applying it to this baby? How am I applying it to this 10-year-old? How am I applying it to this 80-year-old? Principles are the same, okay? So that's why I wanted you to think about where the fluid is, because that's going to dictate what you do. Okay, let me just check. Hyper. I'm not sure, Tenzin, I'm not sure I understood your question.
And Professor, when you told us, right, the fluids will be accumulated inside the baby's tissue. So is there any way we can create a hypertonic environment in the baby's tissue so we can just normalize the fluid, the excessive fluid accumulated in the baby's
The
tissue?
fluid is where is there, right? But what you need to do is to use the chest PT
Mm,
to mobilize to get the fluid to start moving. It
okay.
will be absorbed primarily through the lymphatic system, but the chest PT really kind of jumpstarts that process so that it happens a lot faster. It makes it easier for the baby.
Okay, thank you.
Okay. All right. Cardiovascular adaptation. So we've got our 3 shunts. Let me just see. Okay, I did give you a picture. Okay, 3 shunts. Ductus venosus, which directs blood from the liver to the inferior vena cava prenatally. The fetal liver is not doing as much work because the mom is doing it and the placenta is functioning. So the ductus venosus is in place. The foramen ovale is that small hole between the atria, which helps the blood to bypass the lungs. Again, the lungs are not doing the work of breathing. So the tissues need to be perfused, but it's not doing the work of breathing. So you don't need as much blood going through, cycling through the lungs as you do externally. The ductus arteriosus connects the pulmonary artery and the aorta, same thing. You don't need this blood flow through the lungs. The blood doesn't have to flow through the lungs to get oxygenated. You have a functioning placenta, umbilical cords to take care of that. So once the fetus is born, one of the adaptations, the cardiovascular adaptations, is these shunts start to close. They don't close like the baby's born, the umbilical cord is cut and is clamped and severed, and boom, the shunts close. It doesn't happen like that. It takes a few days to a few weeks for them to actually close. So this is why we may hear murmurs. Sometimes we hear murmurs that are normal. It's just part of the process. The shunts have not closed as yet, but they should close within the first weeks to days to weeks.
Are there any oxygenation issues to worry about during that time? Like, since the blood's not really getting to the lungs fully and all that?
But that's prenatally. Okay, so one of the things that needs to happen is once the umbilical cord is clamped and cut and the baby starts breathing, so I didn't say, the baby starts breathing, the pressure shifts in the pulmonary arteries and the blood really starts flowing now through the lungs to get oxygenated because the umbilical cord is not there anymore. So it's that part of the process happens faster than the shunts actually closing. But again, it takes a couple of days, but they should start to close off.
Professor,
Yes.
Simona here. The fact that the baby breathes with the stomach is something related to this?
No.
I mean, the
It's not
expansion
that
of
the baby breathes more with the stomach. It's just that when you're looking at a newborn, I'll talk about that in a few minutes. When you're looking at a newborn breathing, it's easier to, let me talk about that when I come to it.
Okay, yes.
All right, so just a reminder of the prenatal circulation and then postnatal without the, once the umbilical cord is severed and the placenta is removed. But the main things to remember are that the pressures between the right and left side of the heart now are changed because the baby is now breathing. So that shifts and that changes the circulatory pattern. All right. So assessment of cardiorespiratory status. Obviously, cardiorespiratory status are two of the main things that we need this baby to do to take care of its own breathing now that there is no placenta umbilical cord doing that work. And we, of course, need the heart rate to be steady and within normal limits. So we start with the history always. Was there anything in the pregnancy history, in the labor and delivery history, any complications, anything like that? Any medications, again, checking for any narcotics, whether narcotics that were administered with our knowledge or the narcotics that were not. So if you have a mom that has a history of substance abuse, you need to know about that before, preferably before the delivery, all right? Okay. Normal respiratory rate of a newborn is 30 to 50 breaths per minute. The breath sounds ideally should be clear, but you might have some rhonchi if there's still amniotic fluid in the main stem bronchus, in the main airways. You might have some crackles or rales if there is remaining amniotic fluid in the tissues. Okay, so signs of respiratory distress syndrome. I want you to make a mental note to separate respiratory distress from respiratory depression. Okay? So remember, respiratory depression just means that the system is depressed. The patient is able to do the work of breathing, but neurologically, it is depressed. As opposed to respiratory distress, where there is actually a functional issue. So signs of respiratory distress in the newborn. 3 classic signs are grunting, flaring, and retracting. Grunting, flaring, and retracting. So if you hear me saying GFR, that is what I am referring to. And I'm going to talk more about those in 2 slides. Okay, color we've talked about. We talked about our range from pink to pale to dusky to pink, pale, dusky, cyanotic. So ideally, we want to see pink with acrocyanosis is normal. We've talked about that duskiness to the hands and feet. They may be a little cool. Heart sounds, the full term normal range of the heart rate, 110 to 160, same as prenatally. Brachial and femoral pulses, if we're palpating for pulses, we usually use the femorals. Brachials are a little bit more difficult to discern in a newborn. Blood pressures, we only really follow, I'll talk more about that when we get to complications. We usually don't follow blood pressures in a normal newborn who has no distress. Capillary refill should be the same as what you would expect in any patient. But remember, if your newborn has acrocyanosis, your capillary refill is going to be sluggish, right? The time is going to be diminished. Okay, signs of respiratory distress. So tachypnea, a respiratory rate above 60. Retractions, flaring, so nasal flaring. And then grunting that I mentioned. Those are going to be your main ones. Now, grunting It's what it sounds like. It's an expiratory grunt. So every time the baby exhales, you hear a grunt. And what the baby is actually trying to do is force his or her alveoli to remain open. So every time the baby exhales, you hear a grunt. So that's your GFR plus tachypnea. Those are typically what you're going to see to let you know your baby's getting into trouble. Now, I've said this before, I'll say it again. You always want to catch the problem before it becomes a full-blown problem. So if you see the baby is starting to flare, that should be a red flag. The baby's respiratory rate is increasing, red flag. Try to catch it then, even before the baby starts retracting and grunting. Okay? Now, retractions. What are retractions? Maybe I'm making an assumption here. What are retractions?
Reduction of diameter, I can think. I don't know what they are, but just a guessing.
Did you guys not cover retractions in fundamentals?
We did.
I don't know.
I think,
We
wasn't
did.
that when they were like you see the
The
kind of
diameter.
go between the ribs, like it's sucking in?
So the use of ancillary muscles to support the respiratory effort.
Oh,
So who's got another device? I know some of you are taking your notes on your computer. Who's got another device or can search something very quickly? I need 2 volunteers.
I can do it.
Any-
I can.
Okay, Alice or was that Victoria? I'm sorry, I didn't.
That was Alice and Victoria.
Okay, so Alice and Victoria, you're my volunteers. How many types of retractions can you just search and see what you come up with? This again is important for you to know now, but it will be important for pediatrics. It will be important next semester for when you do respiratory.
I can find 5.
Okay, can you tell me what you found?
There's
Hold on one second. Victoria, did you find yours?
Yeah, I have 5 as well.
Okay, so as you guys go, Alice, I'll ask you to read yours off, and then Victoria, you can say if you have that as the same ones on your list, okay? So,
There's
Alice?
subcostal retractions,
Okay, so hold on one second.
Mhm.
Alice, Victoria, you have those as well?
Yes.
Okay, where are subcostal? What does that sound like? I'm asking the rest of you.
Below the intercostal space.
So subcostals are basically below the ribs, right? That's where you're going to see the indentation, more below. Which one is next? What do you have next?
substernal,
So where's the sternum? So if it's substernal, where are you going to see the indentation?
Below
So
your
this is your sternum, below it. That's where you're going to see the part that you're going to see the patient sucking in, all right? Substernal. Okay, what's next?
suprasternal,
S-U-P-R-A?
yes,
Okay, suprasternal. So where is that?
above the sternum.
That's here.
Like up here.
That's right here. So this is what you're going to see sucking in when the patient's breathing, all right? What's next?
Supraclavicle,
Supraclavicle. So this is the clavicle. So just this small space here, that's what you're going to see, right? And then it should be intercostals, yeah?
yeah, the last one.
So those are the same ones you have, right, Victoria? I saw you nodding, so I'm assuming that those are the same ones, right?
yes.
Okay, so intercostals are the ones that are between the ribs. So you guys, you might be thinking that they are only, retractions are always intercostals. No, there are 5 different types. When your patient is retracting, you have to specify where the retractions are, what type of retractions.
So can you, the subcostal, can you explain those again? Like I'm trying to think of the difference between those and the intercostals.
So so you have your rib cage,
Yeah.
right? It's underneath. That's where you see the indentation, underneath.
Like where the
Not-
diaphragm is.
I'm sorry. Yeah, basically.
Okay.
So subcostal, intercostal, then you have the supraclavicular, suprasternal, substernals. Okay. So it's important if your patient is only having one type of retraction as opposed to retracting everywhere, right? And then you also want to pay attention to, are the retractions mild or are they severe? Okay. All right. So retractions. All right.
Is,
Telectasis.
expanding the other
So Andres, I didn't hear. Simone, I heard you, Andres.
I was saying a telectasis or collapsed lung. Same thing she said.
So it means that one of the lungs collapsed. So you can have a baby that's born. You look at you're ready to count the respirations. You're looking to do your APGARs. You're looking for respiratory effort and you see an asymmetry. That means one of the lungs collapsed and possibly due to the pressure and the stress of the labor and delivery process. Okay, so always looking for symmetry. Always looking for symmetry, all right? Remember, first step of your nursing process is assessment. You have to look first. So even though your inclination is yes to suction and clear that airway, before you do anything, you have to look. Because what's going to happen if you try to nasally suction this baby, this one?
Negative pressure, you're gonna suck in the tissues.
You're gonna
So
cause,
which means what? You're going to cause the baby to?
you might cause a hematoma and take away oxygen as well.
Well, yeah, you're going to say, well, the baby had no oxygen because it's completely, and they're obligatory nose breathers, right? So there is no oxygen, but what's the problem here? What are you going to
you
cause?
don't remove the
You're going to cause an aspiration.
yeah,
That's what you're going to do. If you don't look first and you just push that suction catheter in, you're going to push that tissue into the airway, which is going to cause an obstruction.
Okay.
So you will be the cause of this aspiration. We never want that, right? So always look first to make sure it's patent before suctioning. This baby has a little bit of an airway, not much, a little bit of an airway, but it's still going to need assistance. So these babies might need endotracheal tubes. They may need an oral trumpet, but they need assistance with an airway. They need assistance with an airway, all right?
How is this?
If you have a baby that's not breathing, look first before you suction. It might just be a suctioning issue, yes, but you want to be careful, Fred.
How is the, like, if there's that bony obstruction, like, I mean, how is
That's
that
a surgical-
ultimately taken? Okay, that's what, okay.
Yeah, that's a pediatric ENT surgical situation. Yeah, that baby's going to end up, a baby with a bony obstruction will need to have an endotracheal tube placed, and then that has to be surgically removed.
And what about the one in the
Prevent the
lower,
aspiration.
the one in the lower right looks like it's tissue, not the bone. So
Right.
does that go down like swelling, or does that also have to get removed?
Removed, this one might not require like a surgical procedure as much as the bony, but all of these babies would require pediatric ENT procedure to remove this and prevent aspiration. So it's removing the tissue, preventing bleeding, preventing aspiration. Yeah. Okay. Thermoregulation. Okay, we'll do thermoregulation, then we'll take a break. So initial temps, we usually do rectally still in practice, regardless of some textbooks will tell you, oh, never do a rectal temp on a baby. Some say that you still do it. So, you know, in terms of the literature, the jury is still out on that. In practice, we still tend to do rectal temps on admission. It gives us a core temp, and at the same time, we're also doing an assessment, which I will come to, an assessment of the anal opening. Thereafter, temperatures are done axillary. So your newborns, always rectal or axillary. In the hospital, it depends on your facility. Some of them will do the ear temps, some of them will do the forehead scanners now. But a lot of them actually for infection control purposes will still do the axillary. Okay. Radiant warmers, isolates, bassinets. The one on your left is a radiant warmer. So typically we put the baby here. A temperature probe is placed on the skin surface that is exposed to the heat source. This is the heat source. So you would set the temperature for whatever you want the baby's temperature to be, 98.6, 37. That's what you want the temperature to be. And the radiant warmer will release heat to get the baby to that point. But again, the temperature probe has to be exposed to the heat source, right? An isolate, we usually set the temperature depending on what the baby's gestation is, a little bit higher for your little ones, a little bit lower for your bigger babies. But it's an enclosed environment, so the temperature can be a little bit lower. I'm sorry, yeah, a little bit lower than what you need to set this at. These radiant warmers, remember, are vulnerable to whatever the air temperature is, if there are drafts and so on, whereas this is a closed environment. So anyway, long story short, this is your radiant warmer. This is your isolate. I don't think I have a picture of a bassinet. That's the little bassinet. It's the little miniature crib-like thing on wheels. So a neutral thermal environment, just so that you know what a neutral thermal environment is, this is an environment that you can place the baby in so that the baby uses minimal to no glucose or oxygen to maintain its body temperature. So you want to make sure it's not too hot, it's not too cool. So it's like just the perfect, it's like the perfect comfortable, whatever you think of as your perfect comfortable room temperature, that's what you're creating in your isolate for the baby. That's what you're setting it at. All right. So thermoregulation, very, very important for our newborns. Again, respiratory, cardiac, thermoregulation. Crucial. Those are really, really crucial to this adaptation process. So newborns have thin skin. The blood vessels are close to the surface, so they're more likely to lose body temperature, to lose body heat to the environment. Comparatively speaking, they don't have that much subcutaneous fat. We'll talk about the methods of heat transfer. But the ratio, there's a much higher ratio of the body surface area to their body mass. So they will lose heat rapidly. A baby that is able to flex and position itself in a fetal position is going to maintain its own body heat. A baby that has poor tone, as we spoke about with the APGARs, poor tone, that it just kind of flails out, that exposure is going to cause the baby to lose more body heat. And of course, our preemies are at risk for cold stress. So as I mentioned, it's really important to keep our babies warm. Now, there are 4 methods of heat loss, and yes, you have to know what they are. So evaporation, conduction, convection, radiation. I'm going to start with evaporation. It's the easiest one. So we all know what this is, loss of heat through the conversion of liquid to a vapor. This is why, I'm sorry, let me just Sorry about that. So this is why when our babies are born, we dry them off quickly to prevent heat loss from evaporation. Remember, they're wet, and what we talked about the difference in room temperature. So you want to dry them off, get rid of those wet blankets, wet towels, wet whatever. Make sure whatever is around the baby is dry, okay? All right, so that's evaporation. Whoops. Conduction, you all know, conduction is the transfer of body heat to a cooler solid object. So this is why we tend to warm up our stethoscopes before we put it on the baby's chest. We warm up our hands before we touch the baby. We put a towel or a blanket on the scale before we put the baby on it, so that the baby's temperature, body heat, is not absorbed right into the surface, okay? So conduction. Convection is the flow of heat from the body surface to a cooler surrounding air. So this is why you would not put a baby under an air vent. So if you're in a hospital that the vents are in the ceiling, you don't put the baby under the vent. You don't want that cool air wafting over the baby. Baby's body temperature will be swept away, okay? So you're careful of things like air conditioners, vents, that sort of thing, drafts, drafty windows. I have a drafty window right there, drafty windows. Radiation, transfer of heat to a cooler object that is not in direct contact, not in direct contact. So, if you think about the classrooms on campus, we're facing the water, right? Even if you line up the bassinets along that wall, even if the bassinets are not touching the wall, those babies will lose body heat to that exterior wall. So radiation, okay? 4 methods of heat loss.
Professor, the convection and radiation are kind of a still little bit.
So convection is airflow.
Airflow, okay.
Airflow. So what I always say is think about, so some of you might have a convection oven. If you think about it, that's how a convection oven works. The heated air circulates, right? Whereas radiation is actually more similar to conduction. Conduction, you're losing body heat by direct contact. Radiation, you're losing body heat by indirect contact.
Oh, okay. Thank you.
Okay. You're welcome. So Palavina, do you still have a question? I think that was your question about conduction.
I just wanted another example, please.
So warming, direct contact. So if your hands are cold and you touch the baby, that is going to impact the baby's temperature. So direct contact, okay? It's like if you sit, sometimes you might have been someplace like in a room that's really air conditioned and you sit on the chair and that chair is really cold, you can feel like your body heat gets absorbed into that chair. It's direct contact. Okay, all right. Okay, non-shivering thermogenesis. So again, the thermo being heat, genesis being the creation. So the creation of heat in a non-shivering manner. Babies, newborns rarely shiver. They don't. They just don't do it, okay? They don't have the neurological capacity as yet to do that. So non-shivering thermogenesis allows them to maintain their internal heat. So the first thing that will happen if a baby gets cold, the metabolic rate is going to increase. If the metabolic rate increases, what 2 things are this baby using? What are the 2 things this baby's using? Metabolic rate
Glucose,
increases. You have a newborn that's cold. I'm sorry, what did you say, Fred? I think
Glucose and oxygen.
glucose and oxygen. Okay, so what does this mean for your baby's respiratory status?
Depression.
What I want more than that. It's not going to result in depression.
It's gonna hyperventilate, yeah?
Yeah, hyperventilation.
What I want you to be specific. What does this mean for the baby's respiratory rate?
It's going to increase.
What does this mean for the baby's GFR? What's going to happen with the GFR? Is this baby going to flare? Yes, right? This baby is going to have nasal flaring because he's trying to take in more oxygen. This baby is going to use all of its thoracic muscles to try to pull in more oxygen. This baby is going to start to retract. Okay, so the baby is going to have an increased need for oxygen. And what's going to happen with your glucose? What's going to happen with the baby's glucose level?
It's gonna go down.
It's going to go down. This baby's going to become hypoglycemic. So this baby, what happens when you're hypoglycemic? Okay, I'm going to tell you what happens to me when I'm hypoglycemic. I get a little cranky, right?
Jittery.
So a baby that's a little cranky is going to cry, which takes more glucose and more oxygen, right? So you're already in trouble, okay? And it's going to get worse. So the point here is don't let the baby get cold, all right? It might start as, oh, the baby's just like a little cool, and before you know it, you're on a runaway train, okay? So always remember temperature, respiratory status, glycemia in a newborn. One will impact the other. If a baby gets cold, it's going to use more oxygen and more glucose. If a baby is not breathing well, it's going to need more glucose to do the work of breathing, and it's going to sacrifice its temperature, which means it's going to get cold, which means it will need more oxygen and more glucose. So just keep in mind that those three things are always interrelated, and one is going to impact the other. If one goes down, the other two are going to be impacted, and again, you're going to be on a runaway train, okay? Okay, so we have this baby that's cold, metabolic rate increases. This baby will oxidize brown fat. Now, brown fat is only found in newborns, and the reason it's called brown fat, it's fatty tissue, but it contains an abundant supply of blood cells. So it's a very dark, like a ruddy red, dark red, almost brownish in color. Metabolism of brown fat actually generates more heat than other fats. Brown fat is located in the axilla, above the sternum, along the anterior abdominal wall, around the kidneys, and between the scapula. That's where it's located in a newborn. So your baby gets cold. So if the baby gets cold, going back to what I was saying before, increased metabolism requires more oxygen, more glucose. Hypoxia is going to result in the need for more oxygen and more glucose. This baby needs to continually still produce surfactant. So the baby stops producing surfactant, your respiratory status is going to go downhill. If the baby needs to metabolize brown fat, the baby can become acidotic. That acidosis can lead to vasoconstriction. Vasoconstriction will cause the shunts that are supposed to be closing to open up. So the newborn's body will try to revert back to fetal circulation, but it's already out. All right. So again, you can be in a world of trouble just starting out with the baby being a little bit cool. All right. So the moral of the story here is don't let the baby get cold. All right. So as you can see, cold stress by any of the 4 methods can result in increased metabolic rate, metabolism of brown fat, vasoconstriction. So a whole host of problems that we will talk about over the next week or so, okay? But I gave you the condensed version, which is more than enough for now. Just remember that it will impact respiratory status and your glycemia. Same story, different slide. Okay. All right. So I don't want you to get caught up again in blood values right now. I just want you to remember what we talked about the fetal H&H, fetal hemoglobin, so that you remember how this carries over. So newborns in general have a much higher hematocrit basically than is needed, okay? But that is part of the compensatory mechanism. So they, their levels usually at birth are somewhere between 48 and 69. It can go up as high as 70, it can be as high as 72. So if you think about it, once a newborn once this baby is delivered, do they need all of that extra hematocrit, or that extra hemoglobin? What was the purpose of it? The purpose of it was to get them through labor and delivery, through the stress of labor and delivery. So now that they're here, do they need all of that extra hemoglobin? It's a simple yes or no.
No, they
No,
don't.
no,
They don't. They don't. Thank you. They don't need it. So what happens when red blood cells are broken down? What are the byproducts?
Bilirubin.
So the byproducts are heme and bili, right?
Mhm.
Heme and bilirubin. So this is why newborns are predisposed to having jaundice. Okay, so the higher the crit when these babies are born, if you have a baby that is born with a crit of 72, that baby's going to be jaundiced. That baby's going to be jaundiced. So most babies, if their level is above, if their crits are above 65, they're going to need phototherapy. They're going to be jaundiced, okay? Because now that they're out, their bodies are going to start to break down those excess red blood cells. The breakdown will exceed the rate of excretion, and that buildup is going to cause them to become jaundiced. So we will talk probably what you may think is ad nauseum about hyperbilirubinemia, but over the next few weeks. So I will be coming back to that again, all right? I think that's the main thing that I want you to. Okay, risk for clotting. Risk for clotting. Newborns are at risk for clotting because of the lack of vitamin K. So they need vitamin K to activate the clotting factors. When a newborn, okay, so here's a question for you. When a baby is born, is the GI tract sterile or is it not sterile? What do you think?
This is sterile. There's no bacteria yet, I guess.
So what about the rest of you?
Sorry.
Is the GI tract sterile? Would you say yes or no?
Yes.
Would say yes.
So it is sterile. Now, the normal intestinal flora synthesize vitamin K. So a baby that's born with this sterile GI tract doesn't have the flora to synthesize vitamin K. The baby is going to be vulnerable to clotting deficiencies. So this is why we administer vitamin K within 1 hour of birth. Okay. Hepatic system. Glucose storage. Glycogen is stored during the last few weeks of pregnancy. Glycogen is stored during the last few weeks of pregnancy. So your preterm babies are not going to have it because typically they're born before they even lay down those stores. And sometimes your post-term babies don't have it for a different set of reasons. So it's usually enough. They have enough glycogen to hold them for a few hours if for some reason they're not being fed, which of course we're going to make sure that that doesn't happen. But glucose is rapidly used for energy. Again, if your baby is cold, your baby has any respiratory issues, the glucose requirement is going to be increased. The use is going to be increased. Any sort of stress can predispose to hypoglycemia. So at-risk infants, your preterms and your term babies. Now, your post-term babies. Post-term, remember what I said last week. Post-term baby, placenta, let me finish. The placenta begins to degenerate. Placenta begins to degenerate. The amniotic fluid begins to dry out. But the main thing is that the placenta begins to degenerate. So the fetus is not receiving as much glucose or as much oxygen. So this fetus will start to dip into their glycogen stores. So sometimes you'll have a post-term baby that is born hypoglycemic because they've already exhausted their glycogen stores because they're trying to supplement what little glucose they're getting through the placenta, right? All right, here we go. The story of bilirubin. All right, so in the newborn, conjugation of bilirubin is the major function of the liver. So we talked about the source of bilirubin, the effect of bilirubin. We do not want bilirubin to build up. It is a toxic substance. And its buildup can cause neurological damage. The buildup can cause neurological damage. So.
Can you explain what conjugation means?
I am going to go through that.
Sorry.
No problem. So kernicterus, this is when bilirubin builds up to the point that it is causing neurological damage. Okay. All right. So we have the breakdown. I'm just looking to see which slide I gave you. All right, we have the breakdown of the red blood cells into heme and bilirubin. Now, what we need is the liver to conjugate, to convert the bilirubin into conjugated bilirubin. So you have conjugated bilirubin and you have unconjugated bilirubin. Unconjugated bilirubin is what tends to deposit in the subcutaneous fat. This is why when you look at someone who who has hyperbilirubinemia, why they appear to be jaundiced, why they appear to be yellow, what you're seeing is the bilirubin in the subcutaneous fat, just beneath the skin. That's why they have that tone. Okay, so we need the liver to convert bilirubin into a conjugated form. The conjugated form can be excreted through the GI tract. So most of it is eliminated in the stool, small amounts in the urine, but most of it in the stool. So I'll go back to that in a second. So we have the hemolysis of red blood cells, which leads to our heme and the unconjugated bilirubin in the bloodstream. In the liver, this bilirubin is changed into a conjugated form, which can then be excreted through the GI tract. Now, a couple of things here. If the liver is not functioning, so for whatever reason, you have a baby that's born with a damaged liver, with a liver tumor, the liver is not producing this enzyme that conjugates bilirubin, this system is not going to happen. If you have a baby that has a GI obstruction, that is not stooling, this is not going to happen. If you have a baby that's not feeding, it's not going out and there's no stool, there's nothing for it to attach to, okay? So what we need here is a functional liver and a baby that's being fed for this system to work properly. So ideally, this bilirubin will bind onto albumin and be excreted in the stool. But if this system isn't working, you get this, what we call this hepatic loop. So you don't have to know the details of it. I just want you to know that if the system does not work properly, the bilirubin will just cycle through here and never get out of the body. The more it cycles, it's going to start backing up into this and into the subcutaneous fat and into the brain tissue. So again, bilirubin is a toxic substance. We want it out of the body so that it does not cause kernicterus. Let me see, let me just look back and see. Okay. All right. Oh, so many things to tell you about bilirubin. Okay, so physiologic hyperbilirubinemia becomes visible, like you can see that yellowish tone when the baby has a bili of 5 to 7, thereabouts, which is approximately 3 days. So what's happening for most of our mom and baby pairs at 3 days? Where are they?
Discharge and take it.
On their way out the door.
Yeah.
So this is an important, really, really important part of your discharge plan to make sure this baby is not jaundiced before the baby goes home. If the baby is borderline, you need to make sure that there's a plan in place, that mom knows what needs to be done for this baby. Now, sometimes we will have babies that have to remain in the hospital to be treated for hyperbilirubinemia and the mom is discharged. Okay. Now, physiologic jaundice, so this is what we see around day 3. Pathologic jaundice, and I want you have to know the difference between the two. Pathologic jaundice is just what it sounds like. Something is really wrong here. If you see hyperbilirubinemia within the first 24 hours, that is pathological. Should not happen in the first 24 hours. It's typically caused by a blood incompatibility, like our RH, can be caused by ABO, but ABO is not as bad as RH. Usually it's caused by an RH incompatibility. And there are a couple of other conditions, but that's the main thing that you'll see. All right. So pathological within the first 24 hours, physiologic, which is just the usual body breakdown of the excessive red blood cells, we see around day 3.
Professor, what is like exactly RH incompatibility? What does that mean exactly? I don't understand.
So when we talk about remember when we talked about a mom being RH negative and the baby is RH positive? That.
Okay.
Yeah.
Thank
No,
you.
it's okay. It's a different way of phrasing it. Yeah, RH incompatibility. Okay.
Professor, I don't understand why one would be within 24 hours and one would be around day 3. Is it just how little the baby's body is?
Yeah.
processing?
This is pathologic. This is pathologic. So remember, within 3 days, that's the usual, what you expect with the norm, basically the norm. If it's pathologic, you are seeing it within 24 hours. That tells you right away there's something wrong. You should not see it within 24 hours. If you're seeing it within 24 hours, more than likely, you're looking at an RH incompatibility. So Ruth, in answer to your question, yes. The physiologic one is the one that most babies have where they go into phototherapy. Okay, all right, now. So same story here again. We need this bilirubin to be conjugated and excreted in the feces or in the stool or in the urine. So this baby is jaundiced. You might not see it as well, but she is. Okay. So some of the factors that increase hyperbilirubinemia, the risk of hyperbilirubinemia. So we already talked about the hemolysis of the excessive red blood cells. Remember that red blood cells have a short lifespan anyway. If there is a lack of albumin binding sites, if this baby has a biochemical issue that has resulted in the lack of albumin binding sites, if the liver is immature, any issue with the liver, preterm babies are going to have liver immaturity. They are more at risk for hyperbilirubinemia. Lack of intestinal flora, because the intestinal flora contribute to the bilirubin being conjugated. So a baby that has a lack of intestinal flora is going to have a higher level of bili. I already explained about delayed or inadequate feedings. If there is trauma, so remember the baby that we looked at earlier, the forceps delivery with the hematoma on the face. So remember, hematoma is breakdown of red blood cells. That baby is going to be more likely to be jaundiced. Babies that are acidotic due to cold stress, that is going to factor into their bilis as well. So this baby was a breech presentation. As you can see, that left hip is bruised and also swollen. This baby is going to have a much higher bilirubin than a baby that's not bruised.
Professor, I have a question.
Yes.
So the baby that has that trauma of bruising, does that affect the APGAR score?
Probably not. So heart rate, breathing, color, this baby probably would have the same acrocyanosis, heart rate, breathing, reflex irritability, probably fine.
Okay, thank
It
you.
wouldn't affect the, I wouldn't expect it to affect the APGARs. Now, what
Professor.
might affect the APGARs wouldn't be the bruising, but the baby was a breech presentation. So remember, the sacrum came out first, the head came out last, and that might impact the baby's breathing. Do you understand, Andres?
Yes, I do.
So that might affect the APGARs, but the bruising itself, no. But the baby being a breech baby, yes.
Right. Thank you so much.
Okay, so phototherapy, we put our little people on their own little private beach. Maximum skin exposure. Phototherapy lights, the wavelength of the phototherapy light promotes breakdown of that bilirubin that has deposited in the subcutaneous fat beneath the skin. So again, these babies, we need to make sure they're well hydrated and well fed so that once that bilirubin gets out of the subcutaneous fat, it can get into the GI tract and then out of the body. So maximum skin exposure, we just cover the eyes and keep the babies under the lights as much as possible. They only come out really for feeds and for short periods of socialization with the parents. If the billies are lower, sometimes we have babies that need to go home on phototherapy. We can send them home with a billy blanket. Sometimes we use billy blankets in the hospital, but if you have a baby that needs like 3 weeks of phototherapy, you're not going to keep them in the hospital if everything else is fine. You send them home with a billy blanket. Sometimes we need to treat double bank phototherapy. So just so that you understand, this is single bank, right? There's one bank of lights here, but the double bank, there's a bank up here and the baby's on a billy blanket. So essentially the baby is kind of squished between the two banks. So that, again, you want to maximize skin exposure to the light. So you'll put a baby that has a really high billy under double bank, right? For some babies, single bank might be sufficient treatment. So exposing babies to the sun, depending on the billy, but exposing babies to the sun does not give them the same intensity. So a baby that needs phototherapy needs phototherapy. If a baby is just slightly jaundiced, you know, sometimes some practitioners will still tell the moms, oh, take them out in the sun. But if you think about it on a practical level, how much exposure a baby that is here or here is getting to the wavelength as opposed to outside, how much exposure they're getting to the sun.
And also it's what is also dangerous, I guess, exposing the skin of the baby in the sun,
Yeah.
directly light, right?
It can be, yeah. So a couple of other things, ethnic groups that we see more hyperbilirubinemia in their babies: Asian, Native American, preemies I already mentioned. I think that was it. Okay, that was it. Okay, blood coagulation, I already mentioned vitamin K. Iron storage. Iron is stored during the last weeks of pregnancy. Again, our preemies won't have those stores, just to keep that in mind. When they are in utero, the fetus needs to store enough iron for the first several months because they are not eating, a newborn baby is not eating iron-rich foods. They are eating formula or breast milk. So they're not as iron-rich as their little bodies need. So they really have to store a sufficient supply, right? Medications, many medications are metabolized by the liver. The newborn liver does not metabolize medications efficiently. So we always have to be careful when we're giving medications to newborns. We don't know how they're going to metabolize them. Have to be very careful. Okay, so GI tract. All right, so I'm going to say a few things, and then I've got like a bunch of interesting pictures. So the mouth, so again, we're talking about the GI tract I'm going to talk about the GI tract basically from one end to the other, okay? We'll talk about all of these things, but in case I don't come back to this slide, when we talk about the GI tract, remember that the suck and the ability to suck and having the structure, the anatomy and the physiology to suck, which is how this baby is going to take in its nutrition and hydration, is a part of our assessment. So everything that I'm telling you now is not just, little fun facts. These are all part of your assessment, okay, of this newborn. Initial feeding, we'll talk more about feeds tomorrow, but the initial feeding should be no more than 1 ounce, only 1 ounce. There's still a tendency to overfeed these little ones, and trust me, if you overfeed them, they will give it right back to you, and you will not be happy about it. Coordination. If a newborn is a term newborn that is neurologically intact, should be able to coordinate, suck, swallow, and breathe. This is crucial and a crucial part of your assessment. If a baby is not able to coordinate this, if they swallow, if they're breathing when they should be swallowing, what is going to happen?
Aspirate. And
this baby's going to aspirate. This baby's going to aspirate. So this is an important neurological check. You need to make sure that these babies are able to coordinate, suck, swallow, and breathe, that they know what they're doing and they're doing it in the correct order. Otherwise, you're going to have a baby aspirating on you, right? Okay. So, cleft lip. Now, remember, a baby can have a cleft lip or a cleft palate or both. Did I put it on your slide? Okay. Cleft lip and or cleft palate. It may be unilateral. It may be bilateral. All of those points are important to your assessment. Okay. So surgical repair is possible. These babies will typically have surgical repair. Certainly here in America and other countries, they might not have the capability to do that. We do here. So these babies will have surgical repair. What if you're taking care of a baby that has I'm going to hold that question. So cleft palate, different types of cleft. My recommendation is always, if a baby starts crying, I know your immediate reflex is to soothe the baby. If this is a newborn, your immediate reflex needs to be to look in that mouth. Okay, you don't want the baby to stop crying. The baby opens their mouth and they're giving you a really loud cry. Look in that mouth because you want to look to see what you can see. This small cleft would never have been palpated. This had to be visualized. Okay, so typically what we see, we might see a cleft to the soft palate, might be to the hard palate, maybe both. In these babies, what you will do is use usually your pinky with the pad up to the palate. So 2 things you're doing, you're feeling to determine whether or not the palate is intact, and you're also checking the sucking reflex. So while you're doing that, the baby sucks on your finger, you are able to note the strength, the muscles, the sucking pads, right? And you're checking the palate. Make sure that you avail yourself of the opportunity to visualize. Okay, so you have a baby that has a cleft palate. What's your concern?
And be able to eat.
So PO intake, these babies can feed.
Aspiration.
Aspiration is your main concern here. Aspiration is going to be your main concern. So how do you feed these babies? Oh, so first of all, before we get to that, can a baby with a cleft lip or cleft palate, can they breastfeed?
No.
I'm gonna say no.
No.
Anyone else?
They can breathe. They can breathe. It makes it difficult to like eat and
No, I was asking if they can breastfeed.
breastfeed. Oh, maybe.
Doesn't
No, maybe, yes or no?
I mean,
I don't think so.
Well, you shouldn't allow them to try, right? Because you don't know how they're gonna react to it. It could be bad. I don't know.
So your concern is definitely aspiration, yes. But if you have a term baby, their cardiac status is normal, is normal, is fine. They have no respiratory issues. They can breastfeed. And actually because the tissue of the breast is softer than an artificial nipple, they make a better seal and they actually feed better because the tissue of the body accommodates to the cleft. But what you have to be concerned about and what you have to make sure that you teach the mom is that this baby needs to be upright. Baby needs to be upright.
oh,
Whereas
wow.
they tend to do this kind of cradling. No, you need to have the baby more in an
Okay.
upright position because of the cleft. So you have to think about your anatomy. You want the baby more upright. So that has to be part of your teaching for your mom, how she's going to position this baby.
Professor,
Okay.
so when we're feeding the baby, you said the coordination for suck, swallow, breathing, the combination. So baby with the cleft palate, is that okay for them? That's why I say no, because somehow it's...
So they have to have the coordination, but does their anatomy impact their coordination? The anatomy, this is an anatomical issue, that's one thing, but it should not impact their coordination.
That is a more neurological then?
It is. It's
Oh,
very
okay.
neurological,
Okay.
right? Because they have to know what they're doing and with the order. That's a learned,
So
right?
their anatomy, maybe there's gonna be interfered with something sucking and, that's
So
what
the thing is with the ability to suck, but again, this is why babies who have cleft lip and cleft palate do better with breastfeeding, because it's easier for them than to accommodate to a harder nipple, right? Whereas the tissue of the breast is soft and it accommodates, like it will accommodate to this.
Okay.
So the tissue of the breast would actually fill in here,
Oh,
right, to make it easier, whereas a hard nipple would not do that.
okay, thank you.
Okay, so it's mainly teaching the mom about aspiration, teaching her about positioning, teaching her about pacing. Don't let the baby get so hungry that the baby is just like sucking and, because then the baby is more likely to choke. You want to make sure that the baby is fed as soon as they start to get hungry and so on. Okay, precocious teeth. So out of these three, which one are you most concerned about?
The breastfeeding, probably the teeth.
No, this one, no. Which one of these three babies are you most concerned about? So I'm going to let you put it in the chat box. So this is 1, this is 2, and this bigger picture is 3. So this is 1, this is 2, and this is 3. Which baby are you more concerned about? Whoops. And you're going to have to give me a rationale, right?
Professor, the first one is not, where is the white, the first one on top? Is the white, is that one? Is under the, oh, okay.
This is the precocious tooth.
Oh, okay, okay. I thought it was the,
So I see a lot of 2s, a couple of 1s and 3s. Okay, so those of you who said 2, why is this one? What's your concern?
It looks like it could break off.
And
And if it did, then I mean, there's infection and it, like that kind of stuff. I mean, if it's, I don't know exactly what this is yet, but if it's solid, I mean, is that going to hurt the mother in nursing? You know.
So I want you to look. So okay, others who said 2. Anyone else? What's your concern?
yeah, I agree with Fred for the feeding and also probably the movement of the tongue.
Also, swallowing it, breathing it in.
Andreas?
I was saying pretty much what Fred had said, but also could damage the GI tract.
No, I think what you wrote in the chat box was a little different.
I said, okay, so I said it could harm the mother's breast. It could possibly poke a hole in the fake nipple that you put in the bottle, which would also make the baby probably colicky. And I had also said aspiration of the tooth. So it could either go in towards the lungs, or it can also go into the GI tract, like the small bowel, large bowel, and perhaps even rupture it.
Okay. All right, so those of you, so what's the concern with 1? Was it similar? What about 1 and 3? Were the concerns the same as 2?
Well, for the third one, it looks like the mouth is more obstructed, which could create problems with feeding.
So, okay. So feeding was your concern. Okay. So looking at, okay. Precocious teeth, your main concern is how secure is it? How secure is the tooth? So of the 3 of these, the least secure is number 2, is this one, right? The concern here, and I get what you're saying about feeding, the feeding for the baby becoming more gassy and all of that, concerned about the mom, damage to the breast tissue and so on. But your main concern with this number 2 is aspiration. This precocious tooth is loose enough that this baby could aspirate. This is an aspiration risk. That's the concern here. This one is a little bit much more situated, embedded. These 2 are more embedded, but definitely an aspiration risk here. So again, whenever you have a newborn, that baby starts singing you its tune, make sure you look in that mouth, okay? Look and see what's in there, what should be and shouldn't be, right? Look at the palate, look for any precocious teeth. The main risk is aspiration. Usually they're not large or sharp enough to cause tissue damage to the mom, but your main risk is going to be aspiration.
Professor, and in this case, it's going to be removed.
So anytime you have a baby that has a precocious tooth or precocious teeth, pediatric dentistry has to be called immediately to assess this baby before they feed, before the first feeding. You don't even feed this baby because you don't want to, you don't want to take the chance on that tooth becoming loose and the baby aspirating. So pediatric dentistry has to assess the baby first and determine whether or not the tooth needs to be removed immediately or it can wait. Okay. So aspiration risk. Epstein pearls, these are benign. They are small, white, hard inclusion cysts. They disappear without treatment. There's nothing to be done. They will disappear within a few weeks, but they can be very alarming to the mom, okay? So when you're doing your assessment, no one expects you to actually count how many there are, but you should pay attention to where they are and whether or not they are just, you know, if it's one or two, or if there are clusters, because you have to document this. So they're on the palate, they're on the gum. Where are they? Left side, right side, you know, a few scattered, clusters. You have to quantify it somehow and describe them so that that goes into your documentation. They're not painful. And again, they are benign and they will just disappear. Candidiasis, we commonly call thrush. So a newborn may become infected with Candida albicans during the birthing process. It's usually treated, candidiasis is usually, oral candidiasis is usually treated with nystatin suspension in newborns as well as in adults. Same medication, just how it's administered is a little bit different. So it may appear like almost like the baby has patches of breast milk or formula on the tongue or on the lips, but it doesn't wipe off, okay? It is not painful for the baby unless there are cracks to the gingiva. Now, let's say you have a baby that contracts this during the birth process, and now the baby starts to breastfeed.
Yeah.
One of the things that is very important to your teaching for the mom is exactly how she's doing the breastfeeding, particularly how she's removing the baby from the breast. Because if she develops any cracks in the breast tissue, in the nipple or the areola, then that will become infected, right? Because this baby has candidiasis and the baby's breastfeeding. If she has a break in her skin, she is going to end up with an infection, an infected breast, right? So that has to be a part of our teaching. Okay. Protruding tongue, we tend to see this more with hypothyroidism and with trisomy 21. This is actually the same child as a baby and then as a little girl. She has trisomy 21. But our moms with, this is important to, again, back to your history. Your mom has a history of hypothyroidism. You got to make sure that she's on her thyroid hormones and assess the newborn's tongue, okay? Hypothyroidism in the mother can have neurological impacts for the baby. Ankyloglossia, so we commonly call this tongue-tied. This baby has a really short frenulum, so you can see the baby on your left. The frenulum is much shorter, even shorter than the one on the right. Depending on what's going on with the baby, the frenulum may need to be loosened. And again, anything to do with any oral procedure will be very bloody because the area is very vascular. So it really just depends on how well the baby is able to feed. But our real concern becomes as the baby gets older, if the short frenulum impacts the baby's ability to speak. All right. Okay. Anorectal malformation, I mentioned about taking the temperature and rectally, the initial temperature rectally, and assessing the anus. This is one of the things that we're doing. So you can see this baby on the left has no perforation where the anus should be. Baby on the right has a dimple. So what happens to these babies? What happens to a baby with an imperforate anus? The baby is born, everything else seems to be okay. You've got APGARs of 9-9, insignificant maternal history. And here you are in the nursery and you're about to take the rectal temp and oh, we've got an imperforate anus.
There's a risk for severe constipation. because
But
they can't
it's going to be
pass.
more than constipation, right? There's no anal opening.
How's about
An
vomiting?
imperforate anus. Look at this one. There's nothing here. There's nothing here, right? This one is just a dimple. Andres, you were asking something?
Yeah, I was gonna say, would vomiting, electrolyte imbalance, possible toxic megacolon, would those be things that can occur? If
Yes and no, but and I'll come back to that. I think you'll. What's going to happen to this baby?
Then
We-
it's become septic.
Don't overcomplicate this. Okay,
These-
complicated, right? Does every GI tract need to have an exit?
Yeah.
Yes. Does this
Yes.
baby have one?
Yes,
No.
no.
No. Okay,
So we
now
have to go-
what's going to happen to this baby?
surgical procedure.
Yeah,
Tenzin,
to-
what's going to happen to this baby?
Nothing come out.
Me.
Tenzin,
Colostomy back.
this baby has to have a colostomy.
Yeah.
It's got to come out. That's why I said don't overcomplicate it. You guys were thinking like too deep here. Don't overcomplicate it. Some things are not that complicated. An insignificant history, came in, nice delivery, no problems, and boom, this is what she ends up with. This is devastating. Devastating.
Is this not repairable?
This is not, I'm going to come back to this is not something that you would have noticed on an ultrasound, right? Even a detailed ultrasound is not going to be that detailed. So she would not have known this. This is devastating. That your beautiful baby now needs a colostomy. And now you have to take home a baby and do all of this colostomy care. The same stuff that you talked about in fundamentals, same principles, but for a baby. Okay. So that this baby is going to have this colostomy until the baby is usually until the baby's at least
2 years.
sometimes around 18 months, sometimes around 2 years. It depends. Internally, it depends on what the gut looks like inside, how much tissue there is inside, how much rectum there is inside. The baby will have the colostomy until they grow and until the gut grows large enough, until there's enough tissue that they can actually pull it down and make an anal opening. An anal opening will be surgically made, but there has to be GI tract internally to do that.
Will that result in a proper functioning sphincter? Or is that special care there for that?
So all of that has to be created.
Interesting.
Has to be created.
And
I mean, this one looks like it might have been starting to form, but this is just like nothing. So it really depends on what's internal, right?
Professor, as a nurse, what is your psychological? I mean, the mom, you said she's devastated. How do you approach this
Well,
mom?
I mean, you now you all went through psych. So think about this. This is you're going to find that there are many scenarios, many situations in your career that you have to think back honestly to your stages of grief, right? And remember last week when I was talking to you about letting go of what you thought you were getting and accept this is what is, right? And so it's going through a stage of grief and accepting this, right? And so one of the things that we always try to focus on with children with any sort of defect is not the defect. Because whether or not this baby has a colostomy, this is still your beautiful baby, right?
Yeah, yeah.
Whether or not your child is asthmatic, this is still your beautiful child. We have to deal with the asthma. We have to deal with this. This is still your child, right? So, but you also have to allow that process of grieving and of acceptance. And you've got to get your teaching done and all of that, right? And so this is going to be a baby that's going to be going to remain in the hospital, so, which is another loss. This is a vaginal delivery that went well. Mom's going to be discharged in 48 hours. But the baby's going to be in the hospital for at least a week, having the surgery and getting situated, right? And then you have to teach them. Then the mom has to learn how to take care of this colostomy at home. And then she's going to have a whole host of doctors to follow up with, the surgeon, the GI, the pediatrician. All right? Okay.
Professor, what would have caused this during her pregnancy? Is this like nutritional deficiency or exposure to tetrahydragens?
Sometimes we see imperforate anus as part of a syndrome, and sometimes we just see it just as an odd occurrence with nothing in the history. Yeah. I wouldn't say it's common, but you will, well, I mean, if you work in the area, you will see it. Yeah. I've taken care of a few of these kids. I took care of a set of twins. One twin had an imperforate anus, the other one didn't. Go figure. Everything else was fine, but one had and one didn't. Okay. So the GI, let me see what else I can tell you about this GI system. So I was saying about the mouth that when you're checking for the sucking reflex, which I'll talk about in a minute, the sucking reflex, you're also making sure that the musculature is present and that it's strong and that the baby has sucking pads, okay? At the same time, your finger is in the mouth, you will feel this cleft. Cleft like this you won't feel, but you will feel this gap or a gap like that. All right. So the stomach, I mentioned about the limited capacity. Okay. The rate of peristalsis is fairly rapid. So most full-term babies will eat approximately every 3 hours. Breastfed babies, because of the nature of breast milk, they tend to feed every 2 to 3 hours. Formula-fed babies tend to feed every 3 to 4 hours. But the rate of peristalsis is fairly rapid. The gastrocolic reflex is stimulated when the stomach fills. So that is one of the things that increases intestinal peristalsis and will cause that baby to give back to you or if you overfeed the baby. Now, the cardiac sphincter, where is that? Along the GI tract. The cardiac sphincter, where is it? Between the what and the what?
Esophagus and stomach.
Between the esophagus and the stomach. So remember, it's a round muscle, and naturally in newborns, there's some laxity. And so the laxity of that cardiac sphincter is what contributes to the likelihood of wet burps and vomiting, right? If that sphincter isn't really, really tight, okay? So we need to be careful not to overfeed our little people. So just to give you some points of reference, this kind of gives you things that you can think about in terms of measuring how many mLs. Makes it a little easier. So again, the intestines are very long. Let me see, we'll talk more about absorption tomorrow. Babies do not digest complex carbohydrates. They have limited saliva production. Bowel sounds should be present within the first hour. Bowel sounds should be present within the first hour. What's the other thing I was going to say? Stools, the first stool should occur within the first 24 hours. So meconium is the first stool. It is greenish black and has the consistency of tar. It's very sticky, thick, sticky, tar-like. So should be passed within the first 24 hours. So again, it's really important to make sure we're documenting eyes and nose on these babies and what their bowel movements are, okay? So meconium, it's cells that are shed from within the GI tract, some particles from the amniotic fluid that was swallowed, and so on. It accumulates in the GI tract throughout gestation. So a quick side question. Is meconium sterile?
Well, if it's the first one, should be.
Is meconium sterile? That's it's a yes or no question.
Yes.
So you guys told me that the GI tract was sterile.
Yes.
So that means the meconium has to be sterile, right? So don't get caught up in thinking it's stool. That's probably why you're thinking, oh, that can't be sterile. But it was formed in a sterile environment at a sterile time. So meconium is actually sterile. Okay. So meconium, dark green, black, thick, sticky, tar-like.
So Professor, some fetus, they produce meconium when they're actually not born.
They release it before they're born. Yes, we're going to talk about that when we get to complications, why that happens.
Okay.
Yeah, and the problems that it causes. Yeah. So this is what meconium looks like. Kind of hard to appreciate it in black and white, but that's what it looks like. You can see it's very sticky, very tar-like. Transitional stools, we see these on the second day, third day. They're still fairly dark green, but looser than meconium, a little bit more pasty, starting to be a little bit more pasty. And then thereafter, so meconium, transition stools, and then thereafter you either see the stools that are fairly distinct to breastfeeding babies or to formula-fed babies, depending on what they're taking in. But meconium for all babies pretty much looks the same. Transitional stool pretty much looks the same. So breastfed babies, the stools are seedy and mustard color. Babies who are breastfed tend to stool more frequently, so they tend, it's not surprising to see a stool with every feeding. And the stools have this like sweet, sour smell. The formula-fed babies, the stools are more of a brownish kind of color. They're firmer, more pasty, and have the characteristic odor of stools. So meconium, transitional. These are breast milk stools. You can see they're seedy, kind of mustard yellow and seedy. And this is a formula. I know it's kind of hard to distinguish, but it's more pasty. Doesn't really have the seeds. Those little seedy things are very characteristics of breast milk stools. So any questions about the GI tract? So urinary, our baby should void within the first 24 hours. So it's really important to pay attention to this and to watch for it. Sometimes we'll have babies who void in the delivery room. Sometimes they void in the delivery room. And if we're not paying attention and documenting that, it might seem like the baby has not voided at all. And this baby could be, I don't know, 16 hours of life, and we're starting to get concerned. But meanwhile, the baby voided in the delivery room. Okay. So baby should void within the first 24 hours. We need to watch the average number of diapers. So you should see about 8 diapers per day. And the urine may contain urate crystals. So it's just some of the sediment that has formed within the urinary tract in utero. So if you see this in the first couple of diapers, it's nothing to be concerned about. But again, this is an important thing to make sure that we tell the moms. Okay. Oh, okay. Okay. Hypospadias, epispadias. You have to know the difference between these. And I know it's going to seem like it's anatomy, but there's more than just anatomy here. So hypospadias, the question is, where is the urinary meatus? So it should be at the tip of the penis. If it is not, it's either hypospadias or epispadias. So is it on the ventral surface below the glans penis, or is it on the dorsal surface above? Okay, where is it? All right. So we have to, this is a part of our assessment. If you are lucky enough, because it's supposed to be good luck when baby voids on you, if you're lucky enough and this baby boy is voiding on you, follow the urine stream while it's happening, because that'll tell you right there where that urinary meatus is. Okay. Yeah, it's supposed to be good luck. All right, hydrocele, accumulation of fluid around the testes. So you can see, this is unilateral, this is bilateral. Usually resolves without, in the newborn, it usually resolves without treatment. Hydrocele in an adult is a whole different story, but in the newborn, usually resolves without treatment. Looks like I misspelled that. Okay. So also part of our assessment is to take note of whether or not both testes have descended. So the testes usually start to descend from the inguinal canal around 36 weeks gestation. So if you're taking care of let's say a 37-week baby, you might have one descended and one still in the canal. Okay, but that's an important part of your assessment. Okay. So, male or female? What do you think?
Huh. Complicated.
No, that's not an option.
Could be either.
Not an option.
Female. Oh my goodness.
Male. I'm gonna say male.
It's not. Oh my. Yeah.
So when you're in the delivery room, and I might have said this before, you have to you kind of get used to, when you're around patients, you will learn, you have to learn how to develop a poker face. Okay, there are going to be times, sometimes patients will say things to you that you cannot just have this, you can't let it all out. Okay, you have to have a poker face. Now remember, if you're in the delivery room and the sex of the baby has not been determined by ultrasound, we still have some parents who, they want the ultrasound done for structure and function and all that stuff, but they don't want to know if it's a boy or girl, right? So they might not know what it is. Or let's say you have the mom who comes in that had no prenatal care, or maybe she had a very early ultrasound. And now here you are in the delivery room, the mom's looking at your face, okay? And then what do you do when she says, so is it a boy or a girl? Exactly.
Exactly silent.
Exactly. So this, I don't know. I wasn't able to find out the final on this one. It could be either one. This one could be either one. So last semester? Yeah. Last semester, first half of the semester, during our clinical, the first half, when I did clinical for the first half, we had a baby that had ambiguous genitalia. The thinking was that the parents were, I think, second cousins, if I remember correctly. And so either first or second cousins. And so that was one of the concerns, and the baby was going through a whole host of
Chromosomal.
tests to see what they were going to do. So another one.
what is the
So in
prevent-
these babies, what has to occur is, of course, the external examination, but there also has to be an internal examination, because the question is, what organs are internal? Are there organs internally, and what are they? So sometimes that will help settle some of this. There are hormonal tests that need to be done, and then the chromosomes. So sometimes these babies sometimes parents will opt to have some surgical procedures to clarify things, so to speak. Some will not. It really just depends on what's the full picture.
Yeah.
Okay. And again, culture will play a part in this, and so on. So just, these are not easy cases.
So in this case, okay, say I have a baby with ambiguous genitalia, can I request that they check the hormone level in the blood?
It'll be part of the workup.
Okay.
Part of the workup will be, yes, hormones, chromosomes, checking internal organs. It's part of the workup that's done on all of these babies.
So, Professor, does the ambiguous genitalia change after a certain time?
I'm sorry, say that again.
No, does the ambiguous genitalia change, like, to a male or
No.
female?
Naturally.
I mean, it's just going to grow as the baby grows, right? But that's why I said some parents might opt to later on have some aesthetically, some surgery to, on what's
Define.
wrong with the appearance. Yeah.
But probably, Professor, from a functional point of view, can be altered or not, the functions of reproductive or sexual.
So we don't know. It depends on what's going on inside, right?
Right.
I don't know. I mean, your concern, your immediate question is this baby able to void?
Yeah.
Because that's the main thing that you need to make sure is occurring here, right? As long as this baby is able to void, we can go through all these other tests. We can do all this other stuff. I need to make sure that this baby is able to void and that this baby is putting out the right amount of urine. All the other stuff we can deal with. But right now, that's the main thing. Okay.
Quick question,
So-
sorry, just on the genitalia stuff. Are there ever instances when you have both? Like you have a uterus, you have ovaries, and you got testes?
There have been cases, and I haven't experienced that. What I have experienced is an appearance similar to this, except maybe a little bit more like this, with definite female reproductive or internal reproductive organs with an externally more male appearance. If you understand what I'm saying.
You can't have both, like sexual reproductive things in one person.
That I've not seen, no, to my knowledge. No. So, okay. All right, so I already mentioned about making sure, okay, that the baby should void within 24 hours. I already mentioned that. Nephrons are developed. Now, our newborns do not have, they really don't have the capacity to dilute and concentrate urine the way we do. So we have to be very careful of their hydration status. They can become fluid overloaded very easily. They can become dehydrated very easily. So we have to make sure that we manage that, because they're not able, their little bodies are not able to dilute or concentrate urine. So as a reminder, anytime you are concerned about fluid imbalance, you should be concerned about electrolyte imbalance. And anytime you're concerned about fluid and electrolytes, you've got to be concerned about acid base. They all travel together. Fluid, electrolytes, acid base. Okay, just remember that. So not just, again, not just for now, but going forward, when you start talking about patients with severe dehydration, how does that impact their electrolytes? And once you start impacting electrolytes, you've impacted your acid-base balance. So I just want you to start thinking in that way, okay? All right. I think we might, well, we'll come back to this when we talk about our preemies and complications. Okay, immune system. So our newborns are not, they need help in terms of fighting off infection. Their little bodies are not prepared for everything that they might encounter. Their white blood cells respond, but they respond slowly, they respond ineffectively. So it's not like we just, our bodies respond. They don't produce a fever in response to infections and so on. So we have to be very, very careful with them. So immunoglobulins, IgG crosses the placenta, provides passive immunity for newborns. So this will protect them at least initially. IgM is the first immunoglobulin produced after an exposure. So if you see, let's say you see a particular IgM in a newborn, you have to wonder if this baby was exposed to something in utero, right? So that's the concern with IgMs. But IgGs usually give the babies nice protection, and IgAs are immunoglobulin A. These are the ones that are present in colostrum and breast milk. So when we talk about how early breastfeeding protects the baby from infection, we're talking about IgAs. That's really what we're talking about. Okay, so assessing for anomalies. All right, so head to toe. We talked a lot. I showed you a lot of stuff about the GI tract, but now some other things that you're assessing for in terms of anomalies. So remember that the head is large in proportion to the body. Fontanelles we've already talked about. You know what those are, so check that off your list. Fontanelles should be open. Remember that the sutures are not closed in a newborn, not just because we want the head to pass through the birth canal, but also for brain growth. So those sutures should not be fused. This is about brain growth, okay? So that brain is going to be growing for the first couple of years. So fontanelles should be open, they should be flat, They should not be sunken. They should not be bulging. They should be flat. They should be soft. Okay, so that's an important part of your assessment. Caput and cephalhematoma we're going to talk about. Let me just check the time, make sure. I think we have enough time to cover that. The face. You all do this automatically, but I want you to make sure that you're paying attention to it as part of your assessment with the newborn. So when you look at a face, the features that are there, the usual features that you're expecting, that they're symmetrical and that the movement is symmetrical. So I spoke a little bit about the facial paralysis for that baby with the forceps, but you could have any baby that's born with facial paralysis. You have to pay attention to that, right? So you're looking for symmetry and the movement, bilateral movement, all right? Okay, so for now, I'm going to cover caput and cephalhematoma, and then I think we're gonna be out of time. All right, so anterior fontanelle assessment, again, it should be open, it should be flat, it should be soft. Molding, we have already talked about how the bones will reshape to enable passage through the birth canal. All right, you have to know the difference between a caput, succedaneum, and a cephalhematoma, all right? So a caput is primarily edema. And so I'm going to talk mainly about cephalic presentation babies, okay? So a caput is mainly edema. There may be a small amount of blood, but it's mainly edema from pressure against the cervix. The edema does cross the suture lines. So remember, it seems like way back when I was teaching you about the fontanelles, and I said you have to know the bones, that you have to know the bones. Because if you think about it, how do you know the difference between this and this? You don't know what's going on inside. This is all based on your assessment of your anatomical landmarks, because both of them feel the same. So it's all about the anatomical landmarks. So you have to know where the sutures are, and then you can determine whether or not this fluid has crossed the sutures. If it crosses, it's a caput. If it doesn't cross, cephalhematoma, okay? So caput edema crosses the suture lines, resolves within a few days. I'm going to skip the pictures just to show you. As opposed to a cephalhematoma, which is just what it sounds like, blood, does not cross the suture line and can take weeks to resolve. So those are the main things you have to understand, okay? One is edema, one is blood. One does cross, one does not. One resolves within days, one can take weeks. So you have to understand the difference between them. Because when you look at it and when you feel them, just the same. Okay?
Professor, since the cephaloetoma is blood, you said, right? There's no discoloration of the skin? No. Okay.
Okay. So since I'm here, cephalhematoma is bleeding between the periosteum and the skull. So whenever if you're going to explain to a parent that about a cephalhematoma, you have to be very clear, because once you start saying blood anywhere in the head, they're going to think that you're saying the baby has blood in the brain.
Oh, okay.
Okay. So you have to be very intentional about how you explain this so that you don't alarm them. Okay. Just the thought of that is really frightening. All right. So you have to make it very clear that this is outside of the skull. Brain's inside, this is outside, no brain involvement. All right. Okay. So your caput, we're talking about edema, crossing the suture line, resolving within a few days. Look at this, this even got pitting, okay? So you know that this is a caput because it crosses the suture line. If you can see here, you'll see that this does not cross the suture line. There's a suture line right here. This baby has bilateral parietal cephalhematomas. And you might not be able to see it, but her sclera are yellow. This baby's jaundiced. So remember on the Billy slide, I said any sort of bruising. I showed you the baby with the bruised hip from the breech delivery. And I said cephalhematomas will increase the likelihood of hyperbilirubinemia. This baby's gonna need phototherapy. So when a baby is born and you see cephalhematomas like this, you already know. Let me start introducing this conversation to the mom so that she'll be ready when her baby is under phototherapy, and she'll be ready when she's told that she has to leave the baby in the hospital. Because this baby is going to need at least 10 days of phototherapy, right? So again, you have to start thinking about what all of this means together and what does it mean for your actions and how you're teaching your patient. So another cephalhematoma. Okay, so questions about the difference between the two. No? Okay. All right, we have a few more minutes, so I'm just gonna go on. Ears. So we need to pay attention to the ear placement. So if you draw an imaginary line or line from the outer canthus of the eye to the tip of the ear, that gives you an idea of where the tip of the ear should be placed, okay? It should be at least at that line or above. As you can see, this baby has low set ears. Low set ears are associated with anomalies and things like trisomy 21. Okay, so that's a part of our assessment. So ears, if you have a look at this ear, I mean, you can look at this one, but this got the line on it. What body organ does that look like?
Kidney?
Andrea, was that you, Andreas?
Yeah.
I don't know. I want you to say that like you mean it.
The kidney.
So the kidneys. Ears and kidneys are shaped similarly, and in utero, they develop at the same time. So this is a part of why your assessment of the ears is so crucial. Organs that develop at the same time, if there's something wrong with one, you tend to have something wrong with the other. So you want to pay attention to the ears. So not just where it's placed, but to make sure, look at the shape, look behind it to see if there are any dimples, any sinuses, any tags, anything like that, okay? So chances are if there's something wrong with the ear, there's something wrong with the kidney, all right? Organs that develop at the same time prenatally, there's damage to one, more than likely you're gonna have damage to another one, okay?
Professor, this is only location. What about the auditory itself? There's no problem that listening, right? Hearing?
It depends on how much damage. I mean, we're only seeing externally, and I'll talk about hearing tests, but tomorrow, but we only see externally. There shouldn't be, but we have to, it's got to be part of our assessment. Okay. But you would kind of know, right? As you're going along doing your assessment, you kind of have a sense already if this baby has an auditory issue, just by the way the baby's responding to you and to the environment, right? The baby's not hearing anything. The baby's going to respond very differently, okay? So again, this is what I'm saying. These are assessments that you are already doing that you don't even realize that you're doing. But on your newborns, you have to make a point of paying attention to all of those assessments because they need to be documented. All right. Okay. Cranial nerves. I know that you all remember every single one of them. You remember them and you remember them in order. They will not be on the exam next week. What?
No, nothing.
Don't worry, they won't be on the
It's true.
exam.
It's true. We remember.
At some point, you will have to know them, but not for me. But I want you to just remember that the facial nerve is cranial nerve 7, okay? Because I might say cranial nerve 7, I might say the facial nerve, and you'll know that what I'm talking about and why I'm talking about it because of what we talked about with forceps and facial damage, okay? The facial paralysis, same picture, same story, same baby. Okay. When we talked about the antenatal testing, I had mentioned fat pads and webbing of the neck. This is the picture that I was looking for that I didn't remember to include over there. So webbing and fat pads, this is what we're looking for. You can see that this baby has anomalies, right? You can see this baby has low set ears. And you can see from the shape here, this baby has other anomalies, okay? What do you think of this baby's ear placement? This one.
Yeah, they are too low.
It's low.
So you're low and a little bit back, yeah?
Yeah, it's low. So again, the placement, the shape, you definitely want to fold that ear forward and look and see if there are any sinuses or dimples or anything behind there. Yeah.
Professor, a question. Let's assume that these moms did all the amniocentesis, testing, everything. Ultrasound, nothing was, or probably those anomalies.
Yeah, you would see this on ultrasound. You can see these on ultrasound. Mhm.
Okay.
Yeah, you can definitely see these on ultrasound. All right. The last thing on this slide are clavicles, so I'll just go through it. Please remember, I'm going to ask you all to palpate your own clavicles. Go ahead and do it. So you see how thin, this is a really thin bone, very superficial. Even for us, this is an easy bone to fracture if you fall. Very easy for this to be fractured during delivery, especially of a large baby, okay? So definitely want to, if the baby is large, you definitely want to make sure that you assess the clavicles. Note any crepitus, any, it feels like grainy, any tenderness, any lumps. The baby may have a clavicular fracture. We'll talk about shoulder dystocia when we get to complications, but this is what it looks like on X-ray. So you can see if you're palpating this clavicle, it's not going to be a smooth line. You're going to feel that ridge. All right. And you know that this baby has a fracture. So these babies, or you will feel this bump. These, they heal very easily, actually. So basically what the mom will be taught to do is to sling the arm to keep the clavicle in place. And the ends of the bones really do fuse fairly quickly, but she needs to, it's about keeping the baby in position for what will naturally happen to happen. All right. Okay, last point. I don't expect you to know all of this, just another reminder. Pay attention to how the extremities are moving. This baby had a palsy because of damage to the nerve plexus in the neck. When the baby was being born, the way the neck was manipulated damaged the nerve plexus in the neck, and so the baby was born with paralysis of that arm. Okay, so important part of your assessment.
And Professor, these are not temporary, are permanent damages?
It depends on how extensive. Sometimes they sometimes the nerves do recover, sometimes they don't. Sometimes they recover and not fully. Yeah. Gotta be careful. Yeah. This is why, as I said, a lot of there's some docs that will only do the GYN portion. They won't do anything with obstetrics because there's so many things that can unfortunately go wrong and then end up in a lawsuit. Scary. Okay, so I'm gonna stop here at the umbilical cord. And we'll pick up from here tomorrow. Are there any questions? I have some things that I'm going to load onto Blackboard for you.
More.
Professor,
What is the visa?
Oh, I'm going to, those of you that need that, I will send that by email. What I said I would post is the EAQ and the case studies. Those will be on Blackboard. I'm going to do that as soon as we finish. There was another question.
it was me, Victoria. Sorry, I just missed at the very beginning. I know you said that we would do the exam 2 review following exam 2, but was there anything discussed regarding the possibility of an exam 1 review?
I said the exam 1 review, I will review with tomorrow, but it will be the same review that the exam will not be visualized. But I will make time next week after we have the exam, we have lecture, then we will do the looking at the second exam, and at that time, those who wanted to see the first exam could do that.
Okay, all right, that's the part that I missed, was that we would be able to do that. Do we need to like make an appointment with you for that?
Or what?
Like
Which one? We just talked about 4 things.
If we're gonna stay afterwards.
It has to be, no, we'll all be in the same room. It's going to be, and it'll have to be fast because we have limited, remember, they're not extending our time on campus. So I'm going to eke out a few extra minutes to do it. So you wouldn't have to make an appointment to do it.
Okay.
Yeah.
Thanks.
You're welcome. Okay. So other questions?
Yeah, Professor, one more. Sorry, about this cross puzzle, the newborn. This is for our review for the exam. Okay.
It's, yeah. Some of it you might be able to do today. Some of it you might have to wait until tomorrow. And then I'll post the answers later in the week.
All right. Thanks.
You're welcome. So I know there were a few who had questions for office hours. I will be back. I think I'm just going to leave the Zoom on. Hopefully, I don't think they'll kick me out. So I'll just leave it on and then I'll be back at 1. I just want to post, do what I have to do on Blackboard, and then grab a quick snack, and then I'll come back for office hours. Okay.
Professor, can you just verify again, like what's going to be covered for the coming test? Which?
Oh, wrong. I did see. Okay. So what did I say? Remember the last little bit that we had from the fetal monitoring? The end of that lecture. Postpartum, pain management, procedures, newborn.
Okay, thank you.
You're welcome.
I'm sorry, Professor. I also heard you said that newborns don't.
Oh, yeah, I didn't come back to your question. They do not. They typically do not become febrile. No, we'll talk more about that in complications, which when we talk about sepsis in the newborn. But basically, newborns tend to have temperature instability. They don't become febrile with infection. Thanks for reminding me, I forgot.
So Professor, you said we can come back at 1 if you have any questions?
Okay. Be back at 1. All right. Was there another question?
Yeah, Professor,
ahead,
is it all the slides for newborns that will be in Unit 2 exam? The slides you uploaded with nutrition and
Finish assessment, and then we have nutrition and discharge planning, whatever we cover tomorrow.
But you didn't upload the nutrition slides on the Blackboard yet, right?
It should be there.
yeah,
It's in a separate, it's in another,
Yeah, the newborn feeding is there, I guess.
it's in a different, it's in the next folder,
Yeah.
because that's tomorrow. That should be tomorrow's folder. Okay. So I will see some of you back at 1. Okay. Otherwise, I'll see the rest of you tomorrow.
Thank you, Professor.
You're
Thank you,
welcome. Have a good
everybody.
day.
Bye. Have a good day.
Thank you. Bye, guys.
You're welcome.
Hey, buddy.
Thank you. Have a good day.
Bye guys, thank you.
Professor. Professor.
I can hear you.
Hello.
Yes.
You want me to stay because I had a review?
At 2, right?
Yeah. So
Okay.
at 2, how I'm gonna meet you? That's why.
So I'll be here. You can just log back in.
Oh, okay. I'm gonna log in at 2 then.
All right. I'll see you later.
Okay. Thank you, Professor.
You're welcome. Okay.
Bye-bye.
I'll be back. Okay.